I'm psyched to be able to talk to you guys today a little bit about trauma-informed care and more kind of from a kind of a clinical perspective, and then maybe with a little bit of a discussion about some macro concepts as well. So, all right, so here we go. Okay, so we'll start off with a case study. Okay, so imagine if you were working at an organization and you were the receptionist, and a client comes in, and it's a female, and she comes in and she's coming to see her therapist, who is also a female. So the therapist is not there today because she got called away immediately, something about her child in daycare. So the receptionist says, well, your therapist is not here, but we have another male therapist who's here who will be able to work with you. So we would like for you to meet with him. Well, then the client then begins to get visibly upset and visibly nervous because she doesn't want to do that. She says, I want to see my therapist. I want to see the person that I came to see. I don't understand why I can't see the person. I just need to see her. I don't want to see this other man. And then the receptionist keeps insisting, we have this person here that you can see. And then the client continues to get upset about this. So then she gets so upset that she starts like kind of pounding on the desk in front of the receptionist, and the receptionist gets nervous, and so she calls the panic button, and then security comes and removes the client. Okay, so if I would ask you what in the world is wrong with that scenario, well, multiple things. There are many things wrong, but I think the first thing that we might discuss in this scenario is the idea that the organization is obviously not very trauma responsive. The woman came in, it's very vulnerable for her to come to a counseling session or come to get case management or whatever she was there to do. And then the fact that the person wasn't there to see her, that could have been easily handled by saying, I'm so sorry that she's not here. However you would communicate that in a sensitive, compassionate, caring way, but then not force the person to see someone else. Who knows what sort of trauma that she may have had? Maybe there was trauma around with another man, or maybe there was trauma of some sort that she wouldn't want to spend time talking to a guy about some of the issues that she's been dealing with. She's gotten a whole start with another therapist and then have to start just as a Band-Aid with someone else. It just seems like a bad plan. So I think that this is an example of what can go wrong and what can happen and how a client can be blamed for what might be considered sort of maladaptive behavior because they're just responding out of a place of trauma. Also, the fact that she immediately went to sort of an anxiety place is another indicator that she was having a traumatic, probably, reaction and what all is going on there. If only that organization had been able to have a training kind of like you guys are going to have here today. So here's a little parable, another parable. Okay, so there was once a man that would bring his two wolves into the town square every Saturday, and he would have the two of them fight, and they would fight, and every week a different set a different wolf would win. So every week, one week the gray wolf would win, and the next week the black wolf would win, and no matter what, it was always a different. But the thing was that the man who owned the dogs always won the bets. So everybody would be betting on which animal they thought was going to win, and he won every single time. So somebody asked, well, gee, how do you know which one? How do you always winning? How do you know which one's going to win? How do you always win this money? And then he revealed his secret was that the one that is fed ends up winning every time. I feed one and then don't feed the other, and the one who's fed wins. So our thing with trauma-informed care, whether we're doing case management or counseling or any kind of care with other people that have experienced trauma, is that oftentimes people come and their whole life has been feeding the trauma because that's so ingrained in them. So what we want to do is feed the other wolf, is feed what's not the trauma, so that there's a resilience and responsiveness to the situation that someone has experienced with the traumatic reaction. So you can kind of see there, if we just put it that way, it's pretty easy to think, okay, what can I do to help build on the strengths that are already in the person to help them be able to fight off the trauma? How can I better starve the trauma? That means how can I take away the thoughts? How can I take away the constant reflection on the trauma, and then therefore help the person to focus on the strengths they have and other coping skills that they have and other people that they have in their life and other ways of kind of defeating that trauma within themselves. The trauma and the effects of it will always be there, but how can we build up the other parts of the personality or the person so that they can know that they don't have to be a victim to that trauma every time. So let's define what exactly trauma is. So basically, as it says here on the slide, trauma is an event that's upsetting to the person or upsetting to the situation, but overwhelms internal resources. So let me give a little example or a little analogy. I don't know if any of you are paying attention to the news lately when there were several hurricanes that came through the different towns. Like say, for instance, the hurricane that hit Houston. Houston was not ready to take on that much water. So there was so much water that came in to Houston that the systems that they had, the sewer systems and the water drainage systems and all that, and the ground, the earth itself, were overwhelmed. They were over-soaked with this amount of water. So all that water flooded the area, and then everyone had to respond to it in some way. It overwhelmed the system. That's a way of thinking about trauma with a person, that we experience something that's outside the normal human experience, and it's something that overwhelms us. And there might be an overwhelming chemical response. There could be an overwhelming physical response. There could be an overwhelming emotional response. So that's exactly what we would think about as a trauma. So this kind of acknowledges, that definition, I think, acknowledges that there can be different baselines or different set points for a person's trauma reaction. So say, for instance, through my whole life, if I have had only, 3 meals a day and picket fence and everything's just been fine at my home and all the things have been really low stress, and then something that maybe get a bad grade, or the teacher does something, or someone in their life dies, or something like that, then there can be a trauma reaction to that. It can be particular to that situation. But if, on the other hand, someone has lived in poverty or has had a great deal of stress throughout their life, maybe some of the things like that might really set off somebody who had a different setting or a different environmental background. Their reaction to the trauma may be a little bit different. So that's something to just really consider. What's the environmental context in which the trauma occurs, and the experiences that a client or a person may have that to help them understand that this is kind of set into a context. The idea about trauma here also is that it can be a single event. It can be a one-time thing, or it could be something that happens over time. It can be more complicated or more complex. It can come at the person from different directions. It could sort of overwhelm different systems. It could overwhelm maybe visual system. It could overwhelm the digestive system. It could overwhelm the nervous system, all kinds of things. And so here's a couple of examples of trauma: child abuse, near-death experiences. We also include refugees that have come from other parts of the world. That disruption of having to be uprooted from their own home and then having to come here, then that we would consider that to be a traumatic reaction. Also, just as we hear and read about a lot, that folks that have been through military maneuvers and that there's oftentimes post-traumatic stress disorder that comes along with that. And those also are responses to trauma. So to talk about the impact of trauma here, I love this quote from Bessel van der Kolk, who is quite a scientist in this area. Developmental trauma sets the stage for unfocused responses to subsequent stress. So if someone has experienced child abuse, for instance, in their life, then the response to future events in their life can be defined or can be molded or shaped by that early life experience. Our bodies adapt to the trauma that we have, and then therefore that's what we have in order to respond to future traumas. Okay, so this is something that really does have an emotional, cognitive, and sensory impact on life, on the systems. There are different categories of trauma. We can think about individual trauma, which is when someone is assaulted or someone has life or child abuse within their own home, or there's some sort of illness that occurs within the person. It's just like one person experiencing the trauma themselves. The next level is group trauma. This is when we've seen people that are in the military, or people that are first responders, or people that have been in a category together and they've experienced that same trauma together. So there's a sense of language or sort of a vocabulary around that particular trauma. There's notions of how people can talk to one another about that. So there's two guys in one of my classes that I teach at the university, and they are both veterans. From the very first day, they both almost just like looked at each other and they both understood what they were talking about to one another because they had also been through this group trauma idea. They knew exactly what they were going through. There's a real resilience as that goes along because there's support from that. That last there, community or mass trauma, like natural disasters, almost like the storm that I was speaking about just a second ago. Again, this is one time people talk about it in a way, maybe years and years later, people talk about it in kind of a nostalgic way, I think, because many times people feel such a sense of community or cohesiveness with one another to help themselves recover from that trauma. It can be something that impacts people for years to come. So that's as all trauma does. But this community or mass trauma idea is something that really many people are responding to together. So here's a little example. Maybe if you look at this picture, what do you see when you look at this picture? Maybe do you see a vase or do you see two faces looking at each other? The idea here is that you could look at the same thing and see a couple different pictures depending on how your eye catches it. So the same thing can be said about trauma. Is that no matter who you are, where you are, it may impact you in a different way. There are, of course, many different things that happen consistently across all people that have trauma. There may be some things that consistently happen, but to be honest, every single person that has a traumatic experience is going to react to it differently. Just like that community trauma, so many people are going to react differently, even if the storm or the natural disaster impacts them all the same way. They're all going to have different reactions to it. Some of them may be very similar in nature, but they're each going to be different. So it's important to remember that if someone comes to us and you think, oh, gee, I know exactly what they're doing, I know exactly what's going on with them, that's not probably the best way to handle it. You could think, gee, I know a framework of symptoms or a framework of patterns that people might be living under because of a trauma that they've had in their life. But because they're a unique individual, they have their own take on it or their own individual experience to bring to it. Here's just a little graph, just of one example to show how a report of child abuse is made every 10 seconds in the United States. I mean, look at that. That's pretty significant to think about how often child abuse is occurring in our country. So think about the prevalence of what's going on around trauma just from this one little slide. But this doesn't even mention all the other traumatic events that go on, people being assaulted, responses to storms, responses to people that are in the military, all kinds of things that happen in people's lives that are traumatic. There are two influential studies that are really important to talk about, I think, to kind of give us the context. One was this study that was done in 2007 through SAMHSA, and it was a study that was done between two groups of women. There were significant numbers, over 1,000 women in the two groups that were in each group that were studied. One group that was had not experienced trauma, and the other that had, and they compared their life responses to just daily life. And there were significant differences that were there. So that's important to think about. It's a great study to look at. But another one that's really important that focuses primarily on childhood response to trauma, and this is the ACE study. This was a combination of Kaiser Permanente and the CDC that came together to do a study. And they interviewed or discussed they used 1,700 subjects in this study. And so of those 1,700, 64% of them had at least one adverse childhood experience. And we'll define that a little bit further here in just a second. But the adverse childhood experience would be considered a traumatic experience. And then as we discuss this, it's not just the event that happens itself that's hurtful or harmful to the person, but it's the next responses that build on itself that can lead to a life-threatening situation. So think about it. Someone is abused sexually as a child. Then they grow older, they feel distrustful of adults, they feel unattractive, they blame themselves for what's happened to themselves. So therefore they socially isolate. We all know that social isolation can be a definite problem for folks. It can lead to a lot of physical difficulties. It can lead to a lot of other thought difficulties. Your cognition isn't fully developed when you're socially isolated. There can be all kinds of difficulties from isolation like that. Then you think about the emotional responses. People never really feeling safe, someone not feeling like they're ever going to be able to find someone that they love, whatever responses that they may be going on is bringing about emotions in that, which brings about anxiety, depression, all those different feelings. which all that is negative for you. We call the neurotransmitter that's going through the person's body, we call it cortisol. And cortisol is good in that it energizes us and causes us to respond to difficulty. But if there's so much cortisol going through your body all the time, causing that fight or flight reaction, then your heart beat is racing, your hands are shaking, that's just not good. That kind of constant stress is not good for the human body. The same with cognitive impairment. How we think about things, how we look at the world can be kind of an all or nothing sort of idea. I'm safe when I'm at home, or I'm not safe if I'm out in the world. Different thinking patterns like that that can be difficult to live under. So all the social, emotional, and cognitive impairment that can come as a result of having a childhood trauma then leads to the adoption of behaviors that can be considered maladaptive, and oftentimes are risky for people's health, for the way that their health is. So say, for instance, if someone needs to reduce their anxiety or somehow shut off that constant flood of cortisol, maybe they try to drink a little bit to calm themselves down, and then that drinking becomes a habit, and then that becomes a lifelong pattern which can lead to an alcoholism. Maybe someone starts smoking, continues smoking consistently, and then that causes heart and lung diseases. Then because of that building on top of that behavior, the diseases or disability or the problems that occur because of this can oftentimes lead to early death. So we see this really as a public health problem, not just an individual problem or something that we can try to handle in a one-on-one discussion, but it's something that we could think about. How do we prevent these adverse childhood experiences from occurring? And then how do we help people recover from them? And how do we help people talk about it from an early on, as soon as it happens? Because the longer someone tends to hold on to these things, the more damaging it can be to their physical body and their psyche. So what exactly are these childhood experiences? What are these adverse childhood experiences? Just to put it in one little graph here, they're categorized in abuse, neglect, and household dysfunction. So you can see physical, emotional, and sexual abuse that people experience from their parents, aunts, uncles, teachers, anybody in their life, anyone that might be in their life, a minister, whoever that's in their life, that wherever this abuse is coming from. And along with that abuse comes with so many other elements of I'm not allowed to talk about it, you're not allowed to tell anyone, all those things that come with it that lead to secrecy, and then just it building up in larger and larger amounts of rumination that occur that build it up inside the person. Then there's the concept of neglect that is an adverse childhood experience, when there's physical and emotional neglect. We know it's so important for bonding and for all that to occur in the developmental stages of someone's life. It's just significant as someone develops. So when there's a lack of responsiveness or a lack of physical needs being met, then that is also considered trauma. Then we think of household dysfunction, and there are 5 things here: mental illness in the home, one of the parents being incarcerated, or if there's domestic violence in the home, or if there's substance abuse with one of the parents. That's very disorganizing for children. Oftentimes, you never know how the parent is going to react, or what they're going to be like when the child comes home from school. Those are considered also childhood adverse experience. And then divorce is also included, and I think oftentimes it's a big part of society, of course, but to think about how are people responding to it, or how is it being conveyed to people or handled within the family. Those traumatic events can lead to, as I was saying earlier, behaviors such as kind of shutting down, lack of physical activity, kind of social isolation, which can lead to obesity, smoking, alcoholism, as we mentioned earlier. And then also this can lead to missed work, that people go to work and feel unsafe or anxious, so they don't want to go to work, so they end up losing their job, which impacts their income and impacts their social life, all kinds of things. Then how the behavior impacts physical and mental health. Obesity, diabetes is connected to lack of physical activity or overeating, eating food that's unhealthy. Also suicide attempts, STDs because of multiple sexual partners, all these different things that you can see there that are a part of the response that lead to physical problems in the person. The next few slides are just some things to see how this trauma does impact the human experience. So when you think about alcoholism, the higher the ACE score, and by ACE score, I mean adverse childhood experience, the number of adverse childhood experiences. So if you've had 1, you'll see that you're 6 times more likely to have an alcoholic problem. But if you've had 4 for adverse childhood experiences, you can see significantly more likely to have difficulty with alcoholism. The same with intravenous drug use. 3.5 more times likely to have intravenous drug use addiction or use if you have had 4 or more ACE experiences happen to you in your life. Also, much more likely to have 50 sexual partners if you have had 4 or more ACEs. Also the same with chronic depression, and you can see a slight difference there between men and women. Actually, when it gets up to the number 4 for the ACE score, it gets much higher for women than men. It's consistently higher for women typically. Some of this may be impacted by the lack of reporting. Oftentimes we know that men underreport depression, so that could have a factor here. So I think that the deal is for us to do all that we can to try to nip this in the bud. You may be working with children in your AmeriCorps position, but if you're working with adults, maybe we can think about this whole deal about how trauma can oftentimes be transmitted to the next generation of children. There's been a significant study around children of Holocaust victims. If we think about persons who experienced the Holocaust, there's been a change in them, a change physically in them. We call this change epigenetics. If the gene or the genes are the kind of the hardware, epigenetics could be the discussion about the software. So when someone experiences a significant trauma, that changes their genetic makeup through this process of epigenetics, and then it's passed on. It can be passed on in utero. It can be passed on to the person as they're developing as a baby, as a fetus. So there's that. Also, there was another study that was done of people that were in the 9/11 tower. And so women who were pregnant, and there's a lot of studies that some of the similar trauma reactions are occurring with those children as they grow older because of the trauma response that the mother had. Goes without saying, I guess, that was a horrible traumatic event. And to see how the child of the mother, even though didn't like see it or hear it specifically or was in utero when it occurred, but how that impacts them. So if we're helping and supporting our adults in the way that they care for themselves and the way that they are healthfully responding to trauma, then we're also helping that next generation. Also, if we think about our responses to trauma, how can we work with kids more one-on-one to be able to help them recover from traumas that they may have had, and what can we do to help prevent trauma from occurring in people's lives? So I'm just skip over this case study because I should have thought through this. This is for a live interaction. But okay, something important to think about. When I mentioned that vase or the two faces looking at each other in that slide before, talking about how trauma impacts everyone differently, some of the factors that impact how people view or how they experience trauma or how the reaction to the trauma is lived out are impacted by social and ecological impacts, factors that occur in the person's life. So at that outer ring there, you see that there's a period of time in history. So just say, for instance, even if you think about child sexual abuse or adolescent sexual abuse, that in the 1940s, this would probably not be talked about, and that it might feel very much more isolating because you know that no one else is talking about it. Here in 2017, it is no less painful, no less dire of a situation, but there are some kind of strengthening factors that so many people have been able to come forward, been brave enough to come forward and talk about it. There are support groups, there are other things out there. So you can see how the history or the period in history really does impact the kind of the response or the person's ability to respond. The same can be said about societal beliefs or concepts about an issue. So say, for instance, I think that maybe if you think about how society views sexuality, so say, for instance, a person having 50 or more sexual partners, that's clearly a response to a traumatic event. But if society views that negatively and then labels the person in a negative manner because of this acting out that they are doing, then that probably drives the person even further inside themselves and with a lack of care or respect for themselves. So that's something to think about, how the societal response. Then we can just go deeper. How does the community or organization in which you're a part of respond to this? What interpersonal relationships are there? How would the family view this? I've known many people and worked with many people that have had trauma as younger people or even as older people and never been able to tell even a spouse or family members or parents or anything because of the way that they feel like that they will be accepted or not accepted. And then just individually, what's our individual makeup? What's our set point? Or what's our baseline for being able to deal with trauma or to deal with the difficulties of life in this way? Many of us have different ways of thinking or dealing with stuff, and so it impacts us all so differently. So also you can think about just the nature of the trauma and how that kind of runs through the whole thing, and then thinking about how the cultural influences. So say, for instance, what is the role of extended family in your culture? Does that help with the recovery or resilience factors in trauma, or does it compound the difficulty and maybe the pain or difficulty of talking about it? And I think our culture, oftentimes honor or shame or family of origin kind of issues are experienced differently in different cultures throughout the world. That also helps define how someone will respond to a traumatic event in their lives. This kind of lays that out a little bit further. Bottom line, what I'm saying here are that there are contributing factors to the event of the trauma. We can just break them down into two factors, risk factors and protective or resilience factors. So a risk factor is that if you have a trauma and you've already had experienced multiple traumas prior to this one, if you're already in a social or economic disadvantage, if you live within the context of an environment that's very stressful in itself already, then there you are, you're sort of stuck in that situation. So that can be a risk factor and will compound the difficulty of recovering or responding to traumatic events. The protective factors can be if people already know, I know that this has happened to me, I know what happens to other people when this happens. I have a good base of knowledge about this. Then I've got some other people in my life that I can talk to and share with. That's definitely a protective factor. And then if people aren't piling on stigma about the situation, then that is also a protective factor. Okay, some other things to think about from social cultural factors are your age, whether you're male or female. So for instance, I keep using sexual abuse as being a factor or a trauma here. If a male is a survivor of child sexual abuse, there's a much less likelihood of the person talking about it or owning up to it, as opposed to a female who may feel maybe more likely to report it. No less painful, no less difficulty, but it might be something that just is experienced differently. The pain is still there, but the expression of it or the response to it may be different. The same with age, sexual orientation, whether you're homeless or a refugee, all these things play a factor in how we respond to the trauma. The trauma is deep and real and impactful in every single person, and we need to respect that for every person, but it can be just expressed or lived out a little bit differently in everybody because of these different factors. Okay. Okay. One thing to think about that happens with people who have experienced trauma are emotional difficulties that people have, depression, anxiety, the experience of numbing, where the person sort of turns off their feelings. And these are oftentimes, well, not oftentimes, but most of the time, physiological experiences that people have, which are connected to physical and cognitive responses that people have due to the trauma. We could talk about different ways that the trauma may unfold or impact or steps towards recovery. And we can talk about those things as being the event occurs, and then is the person able to talk about it, or is the person so overwhelmed that they are unable to talk about it for years and years? This type of these stages that are listed here often are maybe spread out differently as far as time. This could be decades, or it could be months, or it could be days or years for how someone may live some of this out. And you can see the things that sort of maybe make this more impactful in a person. So you can see the event occurs, the person is overwhelmed, their system is overwhelmed. Then if there's emotional issues that are going along with it, then when do they feel comfortable being able to talk about it or to speak to somebody about it? Then the concept of denial is really real. There's sort of a disintegration that can occur within the brain, sort of a segmentation of what's happening sometimes that occurs in the brain. People really do deny that it happened, or really curious, was this a dream, or what happened to me? Could this have been real? Then because of the event, there can be often intrusive thoughts that occur within the person. So it might reappear in dreams, it might reappear in thoughts. When you see someone that looks similar to maybe a perpetrator or someone that you were with in the situation, that it can bring it back up, and it is as if the event is happening at that very moment. So you may wonder, gee, why is somebody panicking right now so bad because of some certain thing? It's because the intrusive thoughts are being reminded, and it's almost like reliving it. In fact, I would say it is reliving it. Then if somebody can get some help or some support, then there can be some kind of working through it, walking through it by talk therapy, by maybe some other form of therapy. Those are important things to kind of engage in, and how that happens. And then somehow the completion, being able to go on with life. And this is something that the trauma goes with you everywhere you go, but how you deal with it or how you respond to it is really up to maybe these resiliency factors, your ability to talk it through, the ability to have a community of people to support you in this recovery period. Now, I gave you that kind of 1, 2, 3 step thing, but really, I think when you look at these stages, it's very difficult to say that I go from 1 to 2 to 3. Usually you go 1 to 5 to 4 to 3 to 2, and then back to 2. And so it kind of occurs like that. So I think everybody's different again. We can talk about these steps and these things that happen, but they usually unfold in each person very differently. Okay, I'm going to skip through a couple of these things too. Let's talk a little bit about the human physiological response to all this. Let's talk about the human brain for just a second. We use the word plasticity. The brain is an amazing thing, and it controls everything that we do and helps protect us from all kinds of things. So the plasticity of the brain is something where it's able to develop around the environmental factors in our life. So there's this story of this guy named Phineas Gage. There's his sort of a photograph of him there framed to the left. And then in the middle picture, there's a clip of a little movie about him. And then up on the right-hand side, you see this is what happened to him, sort of a graphic image of what happened to him. He had been working with like kind of some dynamite, and they were clearing out a place for a railroad bed to go through a hilly area. So he was using a tamping rod to hammer into the rocks, so that he could stick in dynamite, and it would blow up, and they could shovel the rocks out of the way and then make a railroad through. Well, one day he was hitting the tamping rod, but the tamping rod had there was gunpowder at the bottom of it, and it set it off, and it shot through his head. So it went through his the temporal lobe and the prefrontal cortex, and you know what? He got up and was able to walk around right after it was over. The doctor came. His life was, of course, impacted. The emotional regulation was significantly impacted, but he was able to have a job and to live on a life for years and years afterwards. So it's pretty, just I think, a testimony to the plasticity of the brain. So when we say that our system has been overwhelmed by a trauma, think about this and think what the brain can do to help us recover or to protect the body or the human experience from the trauma. So when people say that they don't remember a trauma or there's sort of a repressed memory, that's commonly how we refer to it, that's the brain being using its forms of plasticity to sort of bury something away so that you are not suffering from it. Now, eventually that's going to come back and usually kind of cause some form of suffering or difficulty in the person's life. So therefore they need to kind of work through it or think through it, or how can they talk through some of those things. But it's a way of protecting the body to keep the denial is to keep us from constantly being aware of it. And you can just see that's one example of the plasticity of the brain protecting us. So here's just a little example of the brain. So now, most of the time as we think about trauma, we think about that yellow area or that brain area, the brown area down there at the bottom of the brain. That's often where we would call like trauma living in that area. So that is the area that's more old as far as humanity. So like when our kind of great ancestors that were walking around in caves, basically all they had was that yellow and brown area, which was basically fight, flight, or freeze. So when an animal was coming along after them, they'd know whether to fight, they'd kick in the energy to be able to flee, or whether they would just completely freeze. That might be better, and then the animal might walk away if the cave person was able to kind of hide or whatever. So that's what that part of the brain is for, is to keep the body and the human person alive and safe through that kind of response. That's the one that drives the release of cortisol throughout your body, that gives you kind of like goosebumps and shaky hands and a lot of energy, to respond to something. which can become turn into anxiety for people. So say, for instance, if there's something that reminds the person of a traumatic event, then oftentimes that's where it comes from, that kind of area. The brain is enacted there. That area of the brain is enacted and releasing that fight, flight, or freeze response within the human person. Now, as we've developed, as humanity has developed over the years, we still have that yellow and brown part, which is the fight or flight part. But then also we've developed up there in the red part, which is we call the prefrontal cortex, which is logical and verbal and thinking through things, 1, 2, 3. It's a way of kind of talking about or formulating or making sense of things that happen. So the two work together pretty well there. If all things being equal, there may be a traumatic response and you have the fight or flight response that comes. But then also, as time goes on, you may be able to talk logically or respond to it through thinking through things with the red part of your brain, at least according to this picture, the prefrontal cortex. One kind of thing here to think about is that oftentimes people that have had trauma ended up kind of a segmentation of the brain, that the trauma is only hanging out there in that yellow and brown part where you respond only with fight or flight experiences. But yet a lot of times we come in to talk to our case manager or come in to talk to our therapist, and we're engaging that red part of the brain, that prefrontal cortex. We're talking logically or verbally responding to what we see or do or experience. And so that's almost separating the brain. There are different interventions that we try to do to help people engage both parts of the brain, maybe utilizing some sort of bodily work where people can sit on the floor or maybe do some grounding activity. Hey, I know you're anxious right now, but just think about your back against the chair. Think about that. Reflect for a minute about how you're sitting in this chair. You're here. You're now. You're not back where the trauma occurred. You're right here with me, and we're safe. You feel like your feet on the floor. Maybe rub your thumb against your forefinger. Think about it. Be aware of you're here. You're aware of where you are. And then that kind of enacts the body in a way of kind of like engaging the human body in connection with the brain to kind of bring it all together. So you're not just sitting there talking about something which is strictly oftentimes a physiological response. I think where we can kind of engage both things is helping people. We call this grounding, where people feel like aware of the chair that you're in, aware of the room that you're in, aware of your breathing, aware of what you're speaking right now, that kind of stuff. What are you seeing in the room? Kind of connecting yourself to being present to right now. You're not back where the trauma occurred. You're right here in the room with me, and we're safe. That's just one kind of thing to think about as we're working with people that may go into a panic attack or some kind of a flashback or something. So the neurons basically are the things that allow the cortisol to travel throughout our body. You may have learned that in high school physiology or something, but it's something to bring to mind as we think about how people are responding, that the entire body is responding to this traumatic events that occur in a person's life. It's not just one part of the body. It's not just the brain. It's all throughout the body, all the way down to your feet. One thing to think about is this concept of left brain and right brain. The left brain and the right brain are responsible for different things. Sometimes in a severe trauma, the left brain and the right brain sometimes will break down in their communication to one another. So sometimes like some sort of eye stimulation or things like that are what therapists use to kind of help people bring people back and engage a little bit better and get those two parts of the brain talking. For us as case managers, we may not be doing these therapeutic interventions, but we might be engaging people in kind of some kind of walking. Maybe when you're talking with somebody, rather than just sit there and talk, you could go outside and walk around a little bit and talk as you're discussing something, or get active on a behavior to do something. Sometimes playing a game, or playing checkers, or shuffling cards, or who knows what, as you're talking, can engage the body and the brain, or the two different parts of the brain as well together if you're doing something as well as talking about it. Here's an example of a young man that drew a picture. I wish this was in color, but you can see the different colors or different emotions the person was feeling, and he colored in the different parts of the body where he experienced those emotions. That's a pretty cool thing to think about. Draw a picture of your body. Where do you experience this pain? Where do you experience this stress? Let's talk about that. Also, sometimes talk about holding on to something, holding on to a stuffed animal, holding on to a pillow, holding on to a little stone, something like that might help someone be kind of engaged with their body as well as their brain, and being able to talk about some of the traumatic events that have occurred. Something important to consider when we're working with people that have had a significant trauma or some form of trauma reaction is the idea of triggers and flashbacks. So the trigger is the stimuli. It's just like a neutral stimuli that occurs. It may be a smell, it may be a vision, it may be a temperature, it could be a sound, it could be a visual cue, something like that that brings that person back into the traumatic experience. So the brain is automatically going back to the child being abused, automatically goes to the battlefield that one of our veterans might be experiencing, going back to that mentally and then sometimes emotionally and physically inside their own body. So that's a trigger that stimulates that reaction. It's just a neutral thing out there. Sometimes you don't know when it's going to happen. You don't know what's causing it. So the triggers often lead to flashbacks. So the flashback can be, I'm going back into the traumatic event, just kind of like what I was saying. It can automatically take, a trigger can automatically take a person back into that traumatic experience, and then that's where they are, and they're sort of there. They could be there for minutes, they could be for seconds or hours, and then it's important for us to recognize that and help people to kind of talk that out, so that those types of emotional responses aren't dictating the person's life from here on out. So there are different ways that we can try to respond to trauma-informed care. One is more, I guess we could call it kind of clinical, where you're working one-on-one with people. You let them talk about the experience that they've had, maybe walk with them, have them hold the pillow, all those things that I was just talking about. Help people kind of get direction in their life, maybe moving forward to see that, look, this trauma doesn't own me. I'm able to move forward and get some strength from it. And then the organizational leadership sort of approach could be, how do we get our organization to be able to be more responsive? And that's where we're able to just talk about it. Get people together, talk about the concept of trauma, get people to learn more about it, read more about it, so that we know that what happened in that initial story that I talked about from the very beginning, that idea of the receptionist not really knowing how to respond to someone who is truly responding to kind of a trauma. Or maybe she was having a flashback or something like that, but the receptionist clearly didn't know what to do. But if our organizations are responsive and learn how to deal with that kind of thing and think these types of things through, then we can do a great care, a great response for our people. Let me just give a few more things to think about as we discuss this. There's a real shift that's occurring where the traditional approach to things was that you would get a diagnosis. You had anxiety, and this is how how we treat it, without any sort of recognition of the fact that trauma occurs in someone's life, and that the trauma is truly part of the person's story, and that can be the thing that's leading them to have this anxiety or depression. If we're looking at that traditional approach, shifting into a more trauma-focused or trauma-responsive approach, that the person isn't a diagnosis. They're not sick or labeled, but they're injured. So say if I came into the office tomorrow with a broken arm, people in the office wouldn't be whispering behind my back talking about what's wrong with him, what's the thing with him, what's wrong with him, that kind of stuff. They'd come up to me and hopefully say, gee, what happened to you? You got an injury, what happened? Well, then I would describe it. This is the symptom of the injury that I ended up broken and have to wear this cast. It's the same thing with the trauma, that sometimes people's sort of psyche or their emotions are injured, and we're helping the person to recover. And people can recover from stuff, these traumatic events. Let me give you just a couple of ideas for core principles of trauma-informed care. The idea of awareness, just aware in our organizations, in our own work, to know that this is out there. 64% by that one study, 75% by other studies of people have had some level of trauma, just to know that people are having this. Secondly, is to help people know that they are safe here. And I think by just telling people that they're safe, that can do one level of care, but also just showing it, just kind of showing it. And showing that they're safe can lead down to the fourth one there, which is choice. Sometimes people don't feel safe sitting by the window because of one reason or another, or maybe somebody doesn't feel safe sitting more towards the corner when you're in a room. Whatever, to give them the choice, as much choice that the person has. What chair do you want to sit in when we're in our case management sessions? Where do you want to go? What do you want to work on first? What would you like to do today? All those things, is giving as much choice to the client as possible helps them create a sense of safety for themselves, and also to give them a sense of control for themselves. Trauma takes away our control over our lives. And so if we're able to reinstate that or hand that back over to the client through giving them choices, that's a big deal. This concept of trustworthiness, the third one listed there. We want our clients to trust us, but many times people that have experienced trauma have been told over and over, oh, don't worry, trust me, I'm here for you, blah, blah, blah. But really, that's oftentimes something that backfires for the person because that trust has been exploited. One way to approach it is to say to the client, hey, look, I really want to earn your trust. I know you just met me, or I know we've only known each other for a short time. What can I do to earn your trust? Again, that leaves the choice in the person's hand, and it lets them be able to think about it. What is trust to me? How do I know if I can trust somebody? What's that all about for myself? That's a big, important deal. So I think that idea about I want to earn your trust, how can I do so? And then just the last two things that are about collaboration. When we're involved in case management with people, we're not doing something to someone, we're doing something with someone. So we're helping them to be able to work through whatever difficulties in their life, or finding housing, or finding an appropriate job or something like that. We're collaborating with them. We work together. That in itself is empowering, which is the last point there. Whatever we do, if we can do something to give people skill and feel empowered and feel strong in the way that they are and the way that they're approaching their life, then we can really help someone recover from the difficulty of their life because of a traumatic event. So this might kind of wrap up, I guess, our discussion today. But I feel like one final thing to say is how important it is to discuss that as far as assessment, that we should be doing general screenings. I feel like just when you go to the doctor, you get have your blood pressure taken. If you go to the doctor, you get your temperature taken every time. I feel like whenever we go to start a case management relationship, or whenever we go to any kind of person, they should probably talk to us, hey, have you had what sort of trauma, or maybe fill out that ACE score sheet where you can get an indication of what are the traumas, are there any, and how are people responding to it. I feel like there should be a universal screening for this, so then we all know, so that then we can all be able to work together and work these core principles of trauma-informed care. So that's basically where we're at today, just a brief overview of some discussion topics about trauma. And hopefully this will just open your mind to be able to talk more and look more, and to be able to think more about the clients that you are dealing with and those that might have experienced trauma. So thanks a lot for listening to this session today.